What's new in epilepsy treatment? Dr. Burdette?
So, it is absolutely my pleasure to be an active participant in this year's Epilepsy Innovations Conference. And it is even more so my pleasure to get to speak today on some of the advances that we are seeing in the world of epilepsy treatment. And these advances are going to encompass not just some new ideas, some new treatments, but also some new applications of existing treatments. Whenever I think of innovations, if I jump straight into this notion of let's go cutting edge from the get-go, then we're somewhat akin to an unrooted tree. So we need that good foundation. We have to know where we are starting when we are trying to treat epilepsy, to stop seizures, to in fact stop epilepsy. And then we can argue from that basic understanding into the actual innovations that we will discuss. So where do we start? Well, when I was in training, and it may be subtle on your video, but I am an old guy. So I've been around a while, and when I was in training, we thought of seizures, particularly in the realm of focal epilepsy, as coming from a focus. It was coming from an area of the brain. If we could identify and get rid of that area of the brain, then we could move that individual on the way toward freedom from seizures. But as I have evolved, as epilepsy and the study of epilepsy has evolved, we have evolved into this notion of networks. So epilepsy is the manifestation of excessively synchronous firing of a neuronal network. What do I mean by that? Well, generally, when you're dealing with brain function, you're dealing with billions of neurons, but those neurons can be largely divided into excitatory neurons and inhibitory neurons. Excitatory neurons, when they fire, every neuron to which they are synapsed or connected is more likely to fire. If they are inhibitory, then every neuron that they're communicating with is less likely to fire. So when we function in our day-to-day function, when you think your lofty thoughts, you are utilizing networks that have a nice balance of that excitation and inhibition. So here we see a very simplified network, and I have a nerve cell or neuron that is excitatory, and every time it fires, the next one in line is more likely to fire. If it fires, which it may or may not, then the next one is more likely to fire. If it fires, the next one's more likely, ... eventually coming back and exciting the first one. We do have a brake built into the system, so when this fires, this is more likely to fire, but this inhibitory interneuron makes this neuron less likely to fire. So we've got a balance there. And a seizure occurs when the positive side, the excitatory side of that network overwhelms the inhibitory side. So when someone has a seizure, this neuron fires, causing this neuron not just to want to fire, but it does fire. And this one is more likely to fire, and it does fire, does fire, does fire, does fire, comes back to the first, and suddenly we have a situation where boom, 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 boom. A network is firing in an excessively synchronous fashion. And this network is not firing in a vacuum. It is connected to thousands of neighboring neurons. So it tries to get its neighbors to fire, then they get their neighbors to fire. And this, of course, is the foundation for what is a seizure. So with this as a backdrop, this notion that seizures don't come from a single point in someone's brain, they are coming from a network that is overactive, how are we going to affect that network? Well, as we all know, the mainstay of treatment for seizures is anti-seizure medications. And within that realm, we've had some significant recent innovations. And so I'm going to talk about innovations in 4 separate medication areas. One is in the setting of focal epilepsy, where we have a new drug, Cenobamate or Xcopri. I'm going to talk a little bit about LENNOX-GASTAUT syndrome, for which cannabidiol in the form of EPIDIOLEX is FDA approved. I will also talk about DRAVET syndrome, for which both cannabidiol in the form of EPIDIOLEX and stiripentol in the form of Diazepam is approved. And then finally, seizure clusters, a phenomenon that we have identified for ages, but is now becoming identified in a more standardized fashion, for which we have new intranasal formulations in the form of Diazepam or Valtoco and midazolam in the form of NAYZILAM. So focal epilepsy. What is focal epilepsy? The majority of adults who have epilepsy have focal epilepsy. In children, it's roughly a 50-50 split if someone's going to have focal versus generalized. But let me concentrate on focal. With focal epilepsy, we have a network here where my arrow is, that is in the temporal lobe. And this network wants to do that boom, 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 firing out of control thing. And the brain is trying to inhibit that area to keep it contained. And if the brain succeeds, then the seizure will stop, and it may even cause no symptoms. If it causes symptoms, then that will give someone an aura. Of course, an aura is a seizure, and we call it a focal aware seizure. By the old terminology, we would call it a simple partial seizure, but progress, we now call it focal aware seizure. It's focal, and you're still aware of your surroundings and aware of that aura. If that aura or if that seizure continues to spread, then it will spread to memory-forming parts of the brain, in which case a person will lose awareness and perhaps have unresponsive staring. In that case, they have gone from a focal aware seizure to a focal impaired awareness seizure, what we used to call a complex partial seizure. If, God forbid, it spreads to the frontal lobe and just takes off, then that individual will have a hard head movement to the opposite side and then go into a grand mal seizure, what we call a focal to bilateral tonic-clonic seizure. Need to start in one hemisphere. So which of these medications was FDA approved for focal seizures? Well, that is Cenobamate. And I'm going to use generic names here for the most part. So here we see a couple of graphs, and it's a little bit of a busy slide, but let me point out the highlights. So on this left side, on the A side, we see 1, 2, 3, 4 lines that are nicely color-coded for us. And the top line represent or is in a drug study, then they are on their existing seizure medications, and they may either be given for a period of time, in this case 18 weeks, placebo added, which in theory would do very little for their seizures, or a low dose, moderate dose, or high dose of the study drug. And we are looking at what we call median percent change in seizures. So in English, what that means is if you have a 100% reduction in seizures, then you have no seizures. If you have a 50% reduction, you've cut your seizures in half. And what we see is that with Cenobamate, that in the red line, that over 18 weeks, this group, the group that was randomly assigned to get 400 milligrams a day of Cenobamate, had roughly a 70% reduction in seizures, which is pretty good, because people who are in these drug studies are people who have a lot of seizures. So if we look at the right half of this page, here we're looking at how many people became seizure-free. And we'll talk about this notion of freedom from seizures further as the talk progresses. But in this study, we have, let's focus again on the 400 milligram group, this red group, and it was roughly that about 30% of people became seizure-free by week 18. So this appears to be a medication that is very promising. My take-home message from this data is that this is a very promising medication for the treatment of focal seizures. Whenever we're looking at an innovative medication, we of course need to look at the downsides. What are the possible side effects that we should look out for? And on the right side, we see a compendium of possible side effects that occurred in at least 5% of people in the trial. But the three most common side effects were sleepiness. Really didn't separate out that much. So mostly sleepiness and dizziness. We do have, which is, I will add, very common, as I think those of you who have epilepsy or have loved ones with epilepsy will attest, that sleepiness or dizziness are unfortunately not uncommon side effects that we may get from anti-seizure medications. One caveat, though, is that 3 patients in this drug trial experienced what is called a hypersensitivity reaction. And that is a significant allergic reaction that resulted in the persons having to come off of Cenobamate. When they came off of Cenobamate, they did fine, but there is the suggestion that this may be a hyperallergenic drug. With any hyperallergenic drug, we want to start low and go slow. And in fact, that is what the recommendation is with Cenobamate. We want to start at a low dosage and then slowly build it up. And that is reminiscent to me of other medications that have been hyperallergenic. One that jumps to mind would be lamotrigine. Love lamotrigine, very effective medication. Consider myself a lamictophile, but lamotrigine was not a drug that we wanted to start rapidly. We started low, titrated it or built it up slowly, and patients did very well on it. And the indication is that Cenobamate is a very promising drug that we will want to start at a low dosage and titrate slowly. Shifting gears, there is a phenomenon called symptomatic generalized epilepsy. And the operative terms here are symptomatic, indicating that this is a symptom of perhaps some underlying issues with the brain itself, and it is generalized. 1 second the brain is fine, next second both sides of the brain take off. So here we see a cartoon of multiple red spots, multiple of those circuits that want to fire out of control. And once they get going, boom, 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 they kickstart both hemispheres of the brain. So as you can imagine, when we're not dealing with a single focus, it's going to be a bit more of a chore. It's going to be a bit more of a challenge to treat these seizures. 2 examples of symptomatic generalized epilepsies are LENNOX-GASTAUT syndrome. LENNOX-GASTAUT syndrome appears in childhood and is characterized in childhood by multiple seizure types, of which drop attacks or drop seizures, which, as the name implies, involve a fall to the ground, are a not uncommon scenario. So there's risk of injury. They are associated with cognitive impairment and with a specific EEG finding called slow spike wave on the EEG. So as these individuals age, that slow spike wave may disappear, but the cognitive impairment remains, and the multiple seizure types, including the potentially quite dangerous drop attacks, continue. Another example would be DRAVET disorder. It is a disorder characterized by a mutation of the SCN1A gene. And this gene codes for sodium channels. And sodium channels are very important in creating the electrical impulses that we rely upon for normal brain function. The end result is that an individual who has this mutation or a similar mutation will have a strong tendency toward recurrent seizures, particularly prolonged convulsive seizures. So sadly, these individuals will have an increased risk of sudden unexpected death in epilepsy and tend towards slowed issues as well as motor issues, so motor control issues. What medication options do we have for these two rather severe forms of epilepsy? Well, first, let me talk about EPIDIOLEX. EPIDIOLEX is the only form of cannabidiol that is pharmaceutical grade, that is FDA approved for the treatment of epilepsy. And here we see some graphical representation of the effect of EPIDIOLEX on drop seizures. So I'll point out along the bottom of this graph, we've got individuals who had no improvement, as could happen with any drug. I think we've all seen this. A great new drug comes out and alas, it doesn't work for me or my loved one or whatever. But on the flip side, let's look on the right side. These individuals had a 75 to 100% reduction in drop attacks. So in these individuals, it did very well. I, as an epileptologist, tend to have a never say never attitude. I am of the belief that we should try reasonable medications and see, is my patient, is your loved one going to be on this high end of the response group? And here we see with the dark black line that many patients who were on 20 milligrams per kilogram per day. So if I weigh 50 kilograms, 110 pounds, that'd be about 1,000 milligrams a day. That a number of those patients were super responders, between 75 and 100% improvement, a little less response on a lower dose, and with placebo, not likely to do well. Let's now look at Dravet syndrome. EPIDIOLEX also from this pivotal trial was shown to be very helpful for Dravet syndrome. In Dravet syndrome, what is followed, is studied, are the convulsive seizures, the full-blown, knockdown, drag-out, bilateral tonic-clonic, or just clonic seizures. And once again, we want to be down on this right end of the curve. There will be some people who are non-responders, but the majority of patients were responders. So they improved with EPIDIOLEX. And that was, I believe I'm right in saying, our first anti-seizure medication that was FDA approved for the treatment of the seizures associated with. So in brief, with EPIDIOLEX, there are two drug-related side effects that we look out for. If you are on Depakote in some form or fashion, then we keep an eye on your liver function tests. And if you are on clobazam, the brand name would be Onfi, then we want to watch for any evidence of somnolence, because clobazam has an active breakdown product or metabolite called indesmethylclobazam, and indesmethylclobazam levels are markedly increased when it is dosed with EPIDIOLEX. Otherwise, some sleepiness may occur, some gastrointestinal issues with diarrhea may occur. This is generally a well-tolerated medication. Stiripentol, now FDA approved for treatment of seizures associated with Dravet syndrome as well. This drug has been around Europe for many years and is a potentially quite a helpful drug in the treatment, again, of the convulsive, the full-blown bilateral tonic-clonic or clonic seizures. And again, in this graphical representation, we want to be down on this end of the graph, and we see with this nice color-coded orange line that there was a very robust response to stiripentol, with many patients having a 75 to 100% reduction in seizures. With regard to side effects, again, decreased appetite, sleepiness may occur, and then some of our more common side effects that we see with anti-seizure medications in general, such as coordination issues, could be seen. When I think of anti-seizure medications, I go back to the study from Martin Brody and Patrick Kwan in 2000, where they showed that if you take 100 patients who have epilepsy and I diagnose them with epilepsy and I put them on a reasonable anti-seizure medication, 47 of those 100 become seizure-free and 53 continue to have seizures. If I then take those 53 who are still having seizures and put them on another medication by itself, I pick up another 13 people. So first two drugs, 60 people, 60% of people are seizure-free, 40% are still having a seizure. Okay, I'm getting somewhere though. Let me try a third drug by itself. Well, I get one person seizure-free. Well, let me try a combination. I get 3 people seizure-free. Well, heck, it turns out that from their original data, a little over a third of people continue to have seizures despite their best efforts with anti-seizure medication to stop those seizures. They re-looked at their data about 18 years later, and lo and behold, the numbers were almost exactly the same. So it is apparent that despite our best efforts, there is a subset of individuals, roughly a third of patients who come to an epilepsy center who have ongoing seizures despite our best efforts to get them seizure free. So with this representation, we see a large group of individuals with epilepsy. There's going to be a subset of individuals who have uncontrolled epilepsy. So depending whose data you read, that may be as low as a third of patients, although there was a recent study from the CDC where with polling, they identified that there is perhaps even a higher number of patients who continue to have seizures despite reasonable trials of medication. If someone has uncontrolled epilepsy, they may be at risk for clusters of seizures. They may be at risk, a subset of them, for prolonged seizures, and God forbid, there may be a subset who is going to go into what we call status epilepticus, which is one seizure after another without returning to baseline in between. For the purposes of this innovation talk, I would like to focus on the seizure clusters. So this is part of the acute portion of the acute setting, if you will, of epilepsy as opposed to the longer term chronic setting for epilepsy. So a seizure cluster is going to be a very individual phenomenon. If I have absence epilepsy, then I may have a time when I have repeated absence seizures. Those will be relatively mild, knock on wood, but nevertheless would be an unusual collection of repetitive, frequent absence seizures. Perhaps I have Dravet syndrome, and I tend toward clonic seizures, generalized tonic-clonic, bilateral tonic-clonic seizures, that I might have a cluster of closely spaced bilateral tonic-clonic seizures. So a cluster of seizures is a concept for which we don't have a set definition, but it is in a given individual an acute episode of consecutive seizures that recurs over a short period of time, and this cluster of seizures is distinguishable from the person's background, their baseline seizures. So if I have daily seizures, but on some days I, boom, 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 have a series of 3 seizures in an hour, that would be a cluster for me. If I have seizures once a month and suddenly I have 4 seizures in 12 hours, that perhaps could be a cluster of seizures for me. So as you can see, every individual has their own unique definition of a cluster of seizures. Taking this notion, it is estimated that approximately 15% of individuals who have ongoing seizures, despite our best efforts to control those seizures, will have clusters. And if you take the entire epilepsy population, about 5% of people will. So that roughly translates to 150 to 200,000 people in the US are prone to seizure clusters. What do we do for seizure clusters? Well, generally, we prescribe a rescue medication, a rescue drug. And the most common class of rescue drugs that we prescribe are benzodiazepines, that class of drugs that includes diazepam, lorazepam, clorazepam, clobazam, midazolam, and all of the AMs, if you will. And we're going to be looking at two properties of these medications. One is how quickly do they get into the system? So if I am someone who suddenly just flips into a rapid cluster of seizures, then I want a medication administered that gets in fast. If I'm in the hospital, someone will give me a shot IV and get those medications up to speed quite quickly. As an outpatient, it's not really practical to have a loved one stick an IV in. So what is our next best way? Over the years, we really only had one viable option apart from oral dosing of medication that could take an hour to 2 hours to get into one system, and that was rectal diazepam. Rectal diazepam is a diazepam Valium-like gel that is inserted into the rectum, is absorbed. It takes about an hour and a half to fully absorb it, but you start to see effects, beneficial effects from it within about 10 minutes. This year, within the past year, we have had the appearance of two medications that are intranasal. So they're going to be nasal spray type medications that are also benzodiazepines. One of those gets in very quickly, but also exits quickly. So for individuals where you need to stop that seizure cluster and then get back to normal as quickly as possible, that is a consideration. The other one is going to parallel the pharmacokinetics of the rectal diazepam and get in a little slower but have a longer action. So if I tend to slowly ramp up my clusters and I need a longer period of time of sedation, that is something that I may consider. So here we have the three medications that are go-to medications when it comes to seizure clusters. We have the new NAYZILAM, which is midazolam, a form of Versed, if you will. Versed is another formulation of midazolam that is given intravenously. Well, this is specifically to be given intranasally, so NAYZILAM. We have the diazepam rectal gel. Diastat was the original version of this. And then we have Valtoco, which is a nasal preparation that has similar pharmacokinetics, meaning it gets into the system, gets out of the system in a similar fashion with diazepam. When we're looking at these medications, what we look at is a curve like this. So this is time along the bottom, and this is looking at 24 hours. And this starts with the time when the caregiver or loved one of a patient recognizes that their loved one or the person for whom they're caring is having a cluster of seizures. We then see in blue the individuals who were given NAYZILAM, the intranasal midazolam, and we see in black the patients who were given placebo. And we like to see these lines separate because what this tells us is that more patients who got NAYZILAM did not go on to have any more seizures than did patients with placebo. So we basically want to see those lines separate over time. And these separated nicely, the FDA agreed, and now we have NAYZILAM. With regard to side effects, drug, whether it is an oral by mouth benzodiazepine, a rectal benzodiazepine, or a nasal benzodiazepine, our most common side effect is going to be somnolence and potentially headache. Many of those individuals these headaches are driven by post-ictal headaches. It is possible to have a little bit of irritation of the lining of the nasal passages and of the throat as well. So that is NAYZILAM. We don't have these two lines for Valtoco because Valtoco was FDA approved as an equivalent of the diazepam rectal gel or Diastat. But once again, with Diastat or diazepam rectal gel, we see our two lines. We see separation, that more patients who got the rectal gel and again, we see confirmation of similar sleepiness and headache-related side effects. So that is the end of my medication portion of this presentation. So our innovations with regard to focal seizures with Cenobamate, with regard to LENNOX-GASTAUT syndrome with EPIDIOLEX, our DRAVET syndrome with EPIDIOLEX, or with as a form of cannabidiol and stiripentol, and then with seizure clusters. What else do we have to offer? Generally, epilepsy specialists are never say never sorts of people. We want to get you seizure free. So if 1 out of every 3 people do not have their seizures controlled with reasonable trials of reasonable drugs, what do we have? What should we do? Well, the first thing we will do is think this person has events that look like sort of, if it walks like that and quacks like a duck, it's probably a duck. It walks and quacks like epilepsy, but maybe it's a goose. Maybe it's a mimicker of epilepsy, and what we think is quacking is really honking. So we need further investigation. Let's make sure that we're not treating someone who has fainting spells, for instance, or syncope, the technical term for that, with an anti-epileptic drug. So let's make sure we know what we're dealing with. Let's also make sure that we're not on the wrong anti-seizure medications. We have a number of seizure medications that are FDA approved for the chronic daily treatment of epilepsy in the US, but not every seizure medication works for every type of epilepsy. Take, for instance, ethosuximide or Xarontin, very effective drug for absence epilepsy, doesn't do a heck of a lot of good for focal epilepsy. So let's make sure we're dealing with the right treatment. Idiopathic generalized epilepsy, juvenile myoclonic epilepsy, very common form of epilepsy. Pregabalin, a very commonly prescribed medication, often for pain. It also can be helpful for focal seizures, but you don't want to take pregabalin if you have juvenile myoclonic epilepsy. Could very well make your myoclonic seizures worse. So we need to make sure that is the case. And lastly, we will often pursue diagnostic inpatient, so coming into the hospital, video EEG monitoring. And that is going to be done by epileptologists at an NAEC level 3 or 4 epilepsy center. And throughout the state of Michigan, we have a number of very fine epileptologists and NAEC level centers. And all corners of the state are well covered to deal with this scenario. Why do we want to be aggressive? Well, there are many reasons: risk of injury, difficulty obtaining gainful employment, lack of ability or legality of driving. And then we have the mother of all reasons, and that is sudden unexpected death in epilepsy. The worst of the possible outcomes with uncontrolled seizures, and it is estimated that epilepsy-related deaths and SUDEP accounts for over 100,000 years of potential life lost in the US. More individuals die of epilepsy-related issues than of breast cancer every year. So where can we move? Well, we can consider becoming more aggressive. Jonathan Edwards at Medical University of South Carolina did a very nice evaluation looking at the risk-benefit of an analysis, did what's called a marginal analysis. It's something that is done in economics, and applied this to particularly two forms of epilepsy surgery: temporal lobe surgery and lesional extratemporal surgery. So if you have a lesion and your seizures appear to be coming from that lesion, you have a good chance of being seizure-free. So with regard to effectiveness, what is the chance this person is going to be seizure-free? Much higher with surgery in those two instances than with continued trials of seizure medications. What is the risk of injury from the surgery itself or from seizure-associated injury or the medications? They're not that different, running about 2% for surgery, but the mortality rate is significantly lower in the surgery group. So the risk of SUDEP goes down with surgical options. So when we consider surgical options, we have to take the whole individual or interpret things in that context. And so we have resective surgery, which is a fancy way of saying removing a part of the brain, as the most aggressive option that we have. And we have continued trials of anti-seizure medications as the least aggressive. And in between, we have a number of alternatives. And frankly, some of our most exciting innovations are occurring in this middle area, in the area of ablation, implantable devices, and alternative medicines. So if a patient is an individual with epilepsy is risk-friendly, then they're going to be more interested in pursuing these more aggressive options. If someone is risk-averse, and there are times when it's very reasonable to be risk-averse, then maybe we will look toward the less aggressive options. And all of these make sense. Another way of looking at this is ultimately, if I have surgery, I want to be the same person walking out the door that walks in the door. And what really defines us as individuals is cognition, is thinking. We are who we are by how we think. And so let's look at this notion of low cognitive risk and high cognitive risk. And we want to be down here. I want to be the same person I am coming up, leaving the hospital. So I want something low cognitive risk. So if I'm having ongoing seizures, maybe we try continued trials of medication. I've got a low chance of being seizure-free, and there's some cognitive risks to medications, but it's not super risky. If I look at epilepsy surgery, a part of the brain is removed. So there is some risk that there's a little higher risk. But we do have a number of neuromodulation options which are low risk and actually have a chance with some of these of producing an actual improvement in cognition. So ultimately, well, let me move forward to one of our first innovations that I'll discuss on the surgery side, and this is laser ablation. So rather than have a neurosurgeon go in and either put a hole in the skull that is large enough to get in and remove tissue, or to open the skull to remove tissue, a smaller hole, a smaller burr hole can be placed, and using neuronavigational systems, a laser can be introduced, a laser-tipped catheter can be introduced with MRI guidance into specific areas, even hard to get at areas, and can remove that area with thermal ablation. Here is an example of an MRI scan, and we see the track that that catheter took, and we see a thermal map, a heat map of the area that is to be and was removed. So with this approach, we find that, say someone has temporal lobe epilepsy, those patients do have some of the best outcomes when it comes to removing the temporal lobe. If instead we do a laser ablation, the seizure-free outcomes are almost as good, not quite, but almost as good, but the person is less likely to have memory problems afterward. So many of our patients will choose to go the laser route as opposed to removing the entire temporal lobe, depending on the situation. I would argue, and this is just my bias because this is my a particular area of interest, but neuromodulation offers some very exciting options that we did not have a decade ago. So if we're going to resect, physically remove, or ablate, burn out, if you will, a part of the brain, you really need to meet two criteria. I need to be able to prove that that part of the brain that our neurosurgeon, Dr. Patra, Dr. Elisavage, Dr. Ali, or any of the neurosurgeons around the state are going to remove, I need to prove that that person's seizures are coming from one part of the brain, and that if that part of the brain is removed, that person will be the same person walking out the door that walked in the door. And if you meet those two criteria, then you are a candidate for resective or ablative laser ablation procedures. If, however, I can say that your seizures are coming from one spot, but if we remove it, you're not going to be the same person, that would not be the way we want to go. Or if you're having seizures from multiple brain areas, then we don't want to take out multiple brain areas, so we consider other options. And those are what we call neuromodulation. We modulate the brain. We teach the brain to either not have seizures or to be less likely to have seizures. Neuromodulation comes in two flavors: open loop stimulation, which is a metronomic stimulate, stimulate, stimulate on a clock. And then we have closed loop stimulation, which is in response to something. An occurrence happens, ideally a seizure or a surrogate for a seizure, and then we stimulate in response to that. So the first of our devices for the treatment, surgical treatment, neuromodulatory treatment of refractory epilepsy is the vagus nerve stimulator. This was FDA approved in 1997, but we have had some iterations of this that have made it progressively more effective. The most recent of those iterations was approved in 2017. The Sentiva has an aspect to it whereby it measures the heart rate. And it turns out that the most common heart or EKG accompaniment to a seizure is a sudden increase in heart rate. So as when a seizure starts, if someone's heart rate jumps up, this device detects that and it stimulates the left vagus nerve, and attempts to abort that seizure. So this is a form of closed loop stimulation where the device, which is ordinarily firing in a metronomic fashion, gives a little extra impulse in response to a seizure surrogate, this elevation in heart rate. Here we have one of the bits of outcome data. This is from Europe, where they randomized people to either get best medical practice, which is ongoing trials of seizure medication, or vagus nerve stimulator plus best medical practice. And we see an initial improvement with the implantation of the device, a post-implantation effect commonly seen. And then when the device was not turned on, the best medical practice people went back to their previous seizure frequency, but the VNS people dropped as much as 20%. Another innovation is deep brain stimulation, specifically of a deep nucleus in the brain called the thalamus. The thalamus is like a hub that is at the spoke. If it were the spokes from multiple portions of the neocortex, your surface of your brain are connected and interact. And the thalamus has a unique role in being able to affect large areas of the brain. So in 2018, we had FDA approval of a deep brain stimulator from Medtronic called a deep brain stimulator. And it stimulates a part of the brain called the anterior nucleus of the thalamus. So anterior, front. Thalamus is shaped kind of like a football, and it's a nucleus that is in the front of that. And that is targeted, as you can see here. And then those electrodes are plugged into a generator that sits over the chest wall. And this is an open loop stimulator. Stimulate, stimulate on a clock, typically a minute on, 5 minutes off. This is targeting information. Many of our advances and our ability to hit these deep targets rely upon neural navigation, this merging of technologies, and this allows your neurosurgeon to target very minute areas of the brain very accurately. And here are just two ways of looking at outcomes over the years. This is 5-year data. This is looking at a seizure severity score. The higher we are, the higher that bar is, the less severe the seizure. And there was a sustained effect. And in fact, over time, the seizures in these individuals with DBS became progressively less severe. Similarly, this is quality of life. So these individuals, their perception of quality of life, and it had a sustained effect as well. And we see this with all of our neuromodulatory technologies, that over time, they seem to have a cumulative benefit as they train the brain not to have seizures. One of the biggest innovations that has become largely par for the course over the past 2 years, but a decade ago was rarely seen, is stereotactic EEG. And this is the ability to target these specific critical areas of the brain to identify these neural networks. So previously, the majority of our patients would have what we see on the right, these strips and grids that would cover the brain, blanket the brain, and we would attempt to understand what was occurring in these networks from this blanketing of the surface of the brain, but it all too often would leave unmonitored deeper parts of the brain. We see here on the left, though, that this individual has implantations going deep into the brain, and we use our pre-surgical evaluations to figure out where do we need to target, and we can really get a nice definition of where those seizures are arising. And we frequently we rely heavily upon the SEEG or stereotactic EEG monitoring at my institution to guide not only Resective and EEG, but also to guide placement of deep brain stimulators, as we just saw, and the RNS device, the responsive neurostimulator. So this responsive neurostimulator, as the name implies, fires in response to something. So it senses the seizure, monitors the brain activity, detects a seizure, and then it automatically stimulates, sort of trying to defibrillate, if you will, the seizure. And it also allows us to track over time what is happening. So each individual will have their own seizure fingerprint. So here we see an EEG of someone who is having a seizure. Here is the onset of the seizure. We teach that computer to recognize the seizure, and then we tell it, every time you see that seizure, stimulate the brain and try to defibrillate the seizure. And utilizing this technology, regardless of where someone's seizures are arising, whether it be from the temporal lobe, the frontal lobe, the parietal lobe, we have good data to say that we can make a significant difference in that person's life and in that person's seizure frequency. And when it comes to, are they the same person walking out the door that walked in the door? Well, we have neuropsychological data to show that individuals who had this implanted for over a year had significant improvement in their word finding ability, their memory, their higher thinking, and their learning ability. So this device not only helped people's seizures, but they were generally smarter. They did better on these tests of learning. So what has evolved is, if someone has medically refractory seizures, we want to know, can we figure out where they're coming from? If no, then we're going to look at a broader stimulation of VNS, perhaps a deep brain stimulation, perhaps an RNS within the thalamus. We have options. If it can be localized, how many areas, networks can we identify? And if the answer is 1, is it safe to resect? If yes, is it eloquent cortex? Do they need that cortex to be present to be who they are? If the answer is no, are they willing to undergo a resection? If the answer is yes, then they would have a resection or ablation. If there are multiple foci, or the answer is no, or with regard to eloquent cortex, yes, then we look at neuromodulation. And we can use combinations of these therapies, and we may even go in the future in that individual to a more definitive procedure. So it's an exciting time to be an epilepsy specialist, because I would say particularly over the past 8 years, the numbers of innovative treatments on the medication side, on the implantationist side that I have at my fingertips is so much greater than I had in the prior 2 decades. Finally, just to tweak your interest, I'm going to suggest that the next step in innovation may have to do with long-term trending. So long-term trending is looking at your risk of seizures over the long haul. Here we have over about 6 months of data, and we're looking at long episodes, which is from an RNS device, the NeuroPace device. And long episodes are a combination of seizures and periods of time when an individual is more seizure prone. And this individual was doing very well with their RNS. Everything was hunky-dory. Then all of a sudden, all heck broke loose sometime in mid to late September, and then it went back down. I wonder what happened. That could cause seizures. Was started because, as we know, depression oftentimes goes hand in hand with epilepsy. This was not a medication commonly associated with seizures, generally is well tolerated. It was started, and there was an uptick in this seizure-prone states, and in fact, on the upswing of this, a seizure occurred. The medication was stopped, and everything chilled out. So we can use this information to identify in a given individual how likely are you to have a seizure at any given point in time. And finally, taking this notion of trending, this gives us insight into the dynamics of seizures. This is a very interesting study done in the Bay Area by Max Baud, Vikram Rao, David King-Stevens, and colleagues. And what they did was they looked at brain excitability. And specifically, they looked at NeuroPace long-term data over a few years in a handful of patients, and they tracked on a day-to-day basis how epileptiform those patients' brains were. And they found 2 predominant rhythms. There is a diurnal variation. Some people's brains are more epileptiform at night, and some are more during the day. But the majority of patients have this diurnal variation. Additionally, they found a multidian rhythm, a multi-day rhythm, where individuals with epilepsy will go through periods of time when they're more likely to have a seizure, and then when they are unlikely to have a seizure, and then they will become more likely again. And this cycle lasts 20 to 30 days in the vast majority of individuals, male or female. When someone is on the upswing of that excitability, that is when they are most likely to have seizures. So it is theoretically possible that in the coming decade, we will see the advent of the ability to monitor this excitability and its multidian rhythm, and to be able to tell you today is not a good day to go outside, or not a good day to ride your bicycle. You are in a highly seizure-prone state. But a week from now, today, this is the day to go out and go to the zoo. This is the day to go to the epilepsy walk. This is the day, well, every day is a good day to go to the epilepsy walk. But this is a good day to go out and be active. So we may be able to identify seizure-prone days and not seizure-prone days. So the beauty of these innovations is not only do we have new treatments, but we are gaining new insight into the dynamics of the epilepsy process. And with that, I will end. I will hope that I did not lag too much there. And Russ, I will open the floor for questions.
Okay, great. And if you could stop share screen, that would be great.
And
all right, so we have about 15
absolutely.
minutes or so, 10 to 15 minutes for Q&A, and we already have 9 questions I see lined up, so I'm gonna try and get through these as quickly as we can. So first question, is the mechanism of action understood for cenobamate? And are there other AEDs that cenobamate does not play well with? Good question.
That it is early right now for us to comment as far as medications with which it doesn't play well. The identified mechanisms of action are 2 predominantly. It has a GABAergic effect. GABA is gamma aminobutyric acid. That tends to have an inhibitory effect on the epilepsy networks. So it's fighting it in that sense. And it also has an effect on sodium channels that will oppose rapid firing of neurons. So it's attacking it from 2 different angles, which may explain why it is quite an effective medication. There is a tendency for multiple sodium channel drugs not to play well together, but that remains to be seen with cenobamate.
Okay. Because FDA approval was only for LGS and DRAVET, have more people been relying on state or federal medical coverage? Have more of them been able to obtain EPIDIOLEX? For people with drug-resistant epilepsy, essentially, but not LGS or DRAVET.
Sure. Right. You froze for a second, but I'm pretty sure I know the question. It has been my experience with many of these medications that are FDA approved for LGS and or DRAVETs that initially it is very hard to get these medications. But over time, the insurers and those who pay for the medications, it becomes evident that these medications are not being abused and that they are reasonable drugs. So specifically with EPIDIOLEX, I am finding that I'm getting much less pushback and having much more success in getting this for my patients, even if they don't have LGS or DRAVETs.
Right, and I know that Medicaid has added drug-resistant epilepsy to its criteria for whether they'll cover.
Yeah, that was very helpful.
Yeah. Is laser ablation guided by hand or by mechanical form, like the ROSA robot?
It is guided by mechanical form. So we use either Stealth or ROSA, but a neural navigational system is required so that you can hit the targets.
Great. Are there longitudinal studies on laser ablation, or is it too new?
There are early longitudinal studies. The early longitudinal studies say that the outcomes, the rate of seizure freedom is almost as good, but not quite as good as physically removing the brain. Nevertheless, the cognitive outcomes, specifically in the area of memory, are superior. And that, I think we've got 2-year data on that. There may be a little bit more, but that data will continue to come out, but looks very promising.
Great.
Increasing numbers of my patients are opting to go that direction as opposed to the resection.
Right, and you could certainly try that first, and if it doesn't work,
Exactly.
and then go to the resection. So
exactly.
Is it still true that improvements after surgery decline slightly as a person ages?
That is true for resective or ablative surgery, but generally, if you have an early robust response to ablation or resection, then if you stay on medication, the odds are that you're going to continue to do well. Not always, but the odds are. Where it gets complicated is many individuals are not overly excited about remaining on medication and would like to come off medication. Once you're off medication, the rates of freedom from seizures does fall in those two groups. The flip side is neuromodulation, VNS, DBS.
You froze a bit there. You're frozen. So I think you were saying that VNS, DBS, and RNS, all the improvements and reductions in seizure frequency tend to improve over time. So we'll wait and hopefully you'll unfreeze shortly. I'm going to go ahead and read the next question because hopefully it's a fairly long question. So hopefully you can still hear. Oh,
okay, I don't know, where did I cut out, by the way?
You were, I think you were saying that that seizure rates improve over time with neurostimulation devices.
You got it. Yes.
Awesome. All right. So how old is the oldest RNS, VNS, or DBS recipient? And is this person still being monitored? And does this retraining of the brain have any effect on aging, memory, Alzheimer's, or dementia?
I do not know who the oldest is. This would have beneficial effects for seizure-associated memory problems, but would likely, we have no data for how it would affect dementia. I would not expect it to have a significant effect on dementia since that's a separate process, but we don't have data on that.
Okay. Is cenobamate effective for seizures that have been resistant to other medications? So,
yes, that is the group in whom it is studied and the group for whom it is approved.
Okay. Which patients are not well suited for stereotactic EEG monitoring or stereotactic EEG?
If someone cannot have an MRI scan, it makes it quite difficult. That would be the number one. If someone has an issue, say cortical dysplasia over a large area of the cortex, then it makes more sense to put a grid over that area than to do stereotactic EEG.
Okay. If we have seizures well controlled on medications, briefly, what is a breakthrough seizure? And does it imply that the medications are now obsolete for you, or can they still be usable and it was just a fluke event?
If there was no change in the medications, then a, quote, breakthrough event. So breakthrough event implies to me that the individual is pretty well controlled, just out of the blue. A seizure happens. In that instance, we look for reasons. Was there an infection? Was there something else going on? I tend to be on the aggressive side, so my feeling is if you took your medications and you had a seizure, I'm going to make an adjustment. That doesn't mean that your medications are wrong, but I'm going to make an adjustment so that way, the next time this event happens, you're covered.
Okay, great. I don't think we know the answer to this yet, but how well does DBS work for generalized epilepsies, especially juvenile myoclonic and juvenile absence epilepsies? And if we don't know that yet, how theoretically could it work for those?
So this would be an off-label topic for both DBS and RNS. That having been said, there is DBS data from Mexico that suggests that DBS targeting a different thalamic nucleus called the central median nucleus is going to be potentially helpful. And there is a growing body of data with the RNS device. We have 2 folks who have exactly that scenario, again, targeting the central median nucleus of the thalamus. So in theory, thalamic stimulation should be helpful for generalized epilepsy. The data is just now growing, and that could be in the form of DBS, as evidenced by data from Mexico City, and RNS, as evidenced by data from the University of Pittsburgh Medical Center and here at Spectrum.
Okay. Will it be possible to start coming off anti-seizure meds as my RNS implant ramps up?
Yes. You don't want to jump in too quickly. It takes a while. The RNS device does 2 things. It has an acute disruptive effect for seizures, and it has this long-term neuromodulatory effect. We don't want to hijack the process by just rapidly getting a person off medication, but once we're starting to see that neuromodulation, yes, then we can look to reduce the medication burden.
And also related to RNS, what is the youngest age right now that a person can receive RNS, or that person has received RNS?
Ooh, it is FDA approved down to 18, I believe. The youngest person we have done was 14, and the youngest person ever done, there was a child done at Sinai in New York, I believe. The issues are going to be the skull fissures have to have fused because this is being implanted in the skull. So I believe that the individual was 6 years of age.
Okay, great. And one last question, and then we'll wrap it up. Can Cenobamate be used to treat both children and adults? I know it's approved for adults, but do we expect that it will be able to be used off-label for children?
We expect that it will. It doesn't have that approval now, but it would not surprise me if this becomes a medication that is used in pediatric circles as well.
Okay, excellent. Wow, we got through a lot of questions in a short amount of time with great detailed answers and excellent presentation as always, Dr. Burdette.